Dr. Mohamed Shazly.
Hello, hi Toka.
Hello, Dr. Shazly. I'll just read your intro until you're ready with your slide. Okay. So Dr. Shazly is an assistant professor of medicine at Weill Cornell Medicine in Qatar and a cardiology consultant at the Heart Hospital and Aspetar. Dr. Shazly obtained his medical degree from Weill Cornell in 2010 and completed his residency and his fellowship training at Johns Hopkins Hospital and Cleveland Clinic in the US. He's American board certified in internal medicine and cardiology. Dr. Shazly's research interests include digital health technology and the prevention of cardiovascular disease, and he was authored more than 50 peer-reviewed journal articles and book chapters. He has recently founded Ember Medical, a US-based company building next-generation telehealth software tools with a particular focus on emerging and underserved markets. Ember is a leading provider of telehealth in the MENA region. Thank you, Dr. Shazly, for giving us some of your time today to talk about the state of telemedicine in the MENA region.
Thank you, Toa, very much for the kind introduction, and thank you for the organizing committee. It's really wonderful to see this webinar really organized and organization led by a group of wonderful medical students from both Weill Cornell and Qatar University. So I'm really proud of you guys, and you're teaching all of us, the older generation, about telemedicine and its importance, especially in this region. So let me share my screen. If you give me a second here. Sorry, just 1 second. All right, let me try this. Okay, can you see the screen?
Yes, but not in presenter mode.
Yep. All right, how about now?
Yeah.
All right, great then. All right, so today I'm going to be talking about the state of telemedicine in the MENA region. And as Toa kindly introduced me, I'm a cardiology assistant professor at Weill Cornell, but I have also co-founded a telemedicine company called Ember in 2018. All right, so these are my disclosures, which is, of course, I'm a co-founder of Ember, so I have some ownership interest in it. No part of this talk encourages people to use Ember, but I'll show you some data from our platform. So here's what I'm going to do today. I think, thank you. I mean, we've had great talks by all the speakers. They've covered multiple different things about telemedicine. And I think this is, again, going to make my life much easier. So I think what we're going to do today is quickly cover the global telemedicine scene before and after Corona. We're then going to focus on the MENA region, talk about telemedicine in this region, where it's at and where it's going. And then I want to quickly discuss some challenges in the MENA region that are still facing widespread adoption of telemedicine technology, and then quickly how to move forward. So without further ado, let me jump in. All right, so let's talk about the state of healthcare in general, BC. And BC here means before Corona. So despite technological trends like smartphones and internet being ubiquitous and being used all over the world, and even in the MENA region, there are some countries with almost 98% of the population, like in Qatar, have a smartphone. However, healthcare has been significantly dependent on in-person visits. And in-person visits come with their own problems. So, of course, as we know, they're inconvenient for remote patients. Okay, traffic, especially if you live, for example, if you live in Egypt, there's lots of traffic there. So it can take hours to get to the doctor. You get there, sometimes clinic wait times are very long. Again, here, sometimes wait times can be in terms of, more than 15, 30 minutes at least. It also takes a long time to get an appointment if you're trying to get an appointment at one of the big centers. Also, no-show rates, because of the issues, again, with the inconvenience and travel and so on, there's a high no-show rate, and high no-show rate can cost a lot of money. Also, in-person visits have proven very ineffective during crises or disasters like the one that we're going through right now. Suddenly, a lot of places were closed. No one could get any elective kind of procedures or any non-urgent visits. And this actually caused a huge economic losses and even practice closures around the world, including the US. So what was telehealth doing before coronavirus? Well, in the US, of course, the US has been the leader in terms of telehealth adoption, as well as some countries, for example, like Singapore and some other European countries. But despite that, market penetration has only been around 3 to 5%. And that is despite the fact that, some studies have estimated that almost 40 to 70% of clinic visits or ER visits are unnecessary. And that varies a lot depending on location and specialty and so on. But you heard Dr. Suleiman talking about, for example, hypertension visits. Do you really need to go see a doctor? So despite that, the market penetration or the penetration has been very low. There's been reimbursement regulation issues, especially with medical licensing and insurance reimbursement. And the US has, again, led the way in terms of resolving some of these. So there's been some resolution in some of the regulation issues. There's been a resolution in reimbursement issues since 2018. And then another big problem that was facing telehealth before Corona was also inefficient technologies. There were different companies out there. None is really comprehensive. Some focus on GP, some focus on specialty. So if you're a patient, it's really hard to, figure out what is the best solution and whether there's a comprehensive solution or not. Now, how did healthcare delivery change after Corona? So healthcare ED. I think the biggest thing that we've all noticed is that telehealth has become super dominant. Again, it was kind of forced on us, but still it became super dominant. There's been rapid growth since Corona, with almost an increase to up to 650% in some states like Washington. And this was driven by both patients and clinicians. But the effects were patients who were hesitant about using it have started to realize its value. A lot of patients are saying, oh, wow, wow. How did I spend the last few years of my life going to a doctor or visiting a doctor in their office? Clinicians, again, as many of the speakers have pointed out, a lot of them are, leaving their skepticism behind, and they're like, oh, wow, I can actually, see patients through telehealth. I can do physical exams, and I can actually provide value. And I'm not here talking about telemedicine replacing your practice. I'm talking about it augmenting your practice. So COVID-19 has really become a catalyst for telehealth, and it's just here to stay and grow. So we really have to cope up with this change very quickly. Of course, again, with Corona, that led to, overnight, all these, regulatory issues and reimbursement issues that we've been fighting for years suddenly went away. And finally, again, in some underserved markets or emerging markets like the MENA region, which really didn't have any significant telemedicine practice, overnight, people were looking for telemedicine technologies and solutions. And unfortunately, they couldn't find many because there wasn't many in the region. So telemedicine has done so well after Corona that there was a New England Journal perspective published that called it virtually perfect, which, it's very rare for the New England Journal to call something perfect, but anyways. So now let's look at the patient and physician experience after using telemedicine during the pandemic. So almost 60% of those who used it said they'd use it again. 90% reported that the quality of care was as good as or better than in-person care. And almost 60% said that, their trust in providers increased as their use of telemedicine. So these numbers are very, very, of course, they're more on the optimistic side, but it's telling us a story that's different from what we thought all along, that people won't like it, they won't trust the physicians through video, etc. Now, looking at doctors, more than 90% out of the survey said that they used telemedicine, some form or another, could be phone calls, could be video, during the outbreak. And 60% said that they're planning to use it after the outbreak. 93% said it improved patient care, and almost 77% said it contributes to more efficient use of time, which again, something that we're really noticing is, You know, when you're in clinic, you're running around, you're worried about the time and so on. But when you're on telemedicine, you're moving and you're being very efficient. So now what's unique about, now I'm going to move to the MENA scene, and I wanted to show you what's unique about the MENA region that makes it really ripe for telemedicine. Well, almost 90% of the population are under the age of 60, and they're tech savvy. Okay, so a lot of people in the MENA region are very young. 95% speak one language, despite having different dialects, but they still speak one language, at least a written language. The number of doctors per patient is very low. That's the average here, 0.4 doctors per 1,000 patients. Again, varies depending on different countries. And just to give you a perspective, in the US, it's 2.6. In Qatar, it's 2.5. In Egypt, it's 0.5. So it varies a lot, but the average is pretty low. Out of the almost 600 million people in the MENA region, almost 275 have internet access, which is great. So again, this varies depending on country, but in some countries, up to 80% of private healthcare is really distributed in small to medium clinics. So that means that if you're a patient with multiple problems, you're moving from, you know, from one clinic to the other clinic, et cetera, et cetera. There's not really big centers, again, in the same kind of concept as in the US. But again, some countries are different. Like in Qatar, we have big public health system. Doctor visits in most countries are expensive. And they're cash dependent. Insurance is growing, but still not the dominant form. Technology infrastructure is improving. So again, 275 people have internet access. A lot of people have smartphones. People are using FaceTime, etc. So there is the infrastructure to use telemedicine. And then finally, there's a huge taboo on visiting doctors for certain complaints in the Middle East. So for example, mental health. Still, there's this huge taboo of being seen near a psychiatrist's office. Things like STDs. If you're seen next to an STD clinic, wow, huge taboo too. So there's all these things that, you know, would make people want to use telemedicine. So how was the telemedicine in MENA before Corona? So again, very poor adoption by both clinicians and patients. There is no large-scale implementation in any public system or even any large hospitals, really, except for very rare applications such as telestroke, as Dr. Al-Jirdi has pointed out in an earlier presentation. The platforms that are being used, most of them, if they were being used, were rudimentary platforms. Largest have had thousands of patients in a region which has hundreds of millions of people, and mostly GP focused rather than specialty focused. There's some small companies, but again, none of them had enough capabilities to gain traction. No fancy things like integration with remote devices, no formal doctor-to-doctor consultations through telemedicine, etc. So very, very rudimentary, just video talk to a patient. Regulations vary a lot between countries. Some countries you cannot do telemedicine. You cannot prescribe anything through telemedicine. And for example, Qatar had a law against prescriptions. But some other countries had no laws whatsoever and everything is really relaxed. So they vary a lot. And that was also probably kind of contributed towards the poor adoption. And insurance doesn't reimburse. So in essence, the MENA region was significantly behind. So I was in the US at that time in around 2018. And as telemedicine use was increasing there, my co-founders and I were really inspired to bring large-scale telemedicine to the region. We wanted to fill the gap in telemedicine technology in this area, particularly underserved areas, and provide affordable and accessible care. We also wanted to give clinicians, as Dr. Salaman was saying, it's about giving the tools. So we really wanted to give clinicians the tools that allow them to practice telemedicine safely, effectively, and also privately, rather than currently use systems like WhatsApp, etc. And this is what inspired us to start this company. So I'm just gonna show you quickly what we do, because again, it's gonna link to some of the data, but we launched in December 2019 in Egypt. It was the first country that we launched in. And basically through a comprehensive mobile and web platform, we allow doctors to communicate with patients through live text and video. So we provide both options. Of course, it's mostly through cash payments rather than insurance reimbursement for now, but that's coming next. And we're also trying to provide a full remote kind of experience. So we're trying to bring in remote monitoring devices. We're trying to connect with labs and imaging centers and pharmacies and so on. And again, one of the other things that a lot of countries in the Middle East don't really have a formal electronic health record system. Again, Qatar has one, for example, Cerner, which is used by some institutions in the US, but many don't. So what we were trying to do was a mixture of telehealth and also an EHR. And then, so we launched in December of last year, and then in March, this happened. Suddenly, out of nowhere, we got the corona. And how, so now I want to switch gears a little bit and talk about how corona changed the scene in the MENA region. So, for example, in Qatar, what happened was the major public health system here, which is Hamad Hospital and primary healthcare centers, completely switched to using telemedicine except for urgent cases. So 80% of outpatient services were provided through phone consultations. And again, they did phone because, you know, for many years, we did not really adopt telemedicine. So phones were the only kind of thing that, you know, was available to rapidly institute. They were seeing around 5,000 patients, and urgent medical service and kind of phone consultation, seeing around 5,000 patients a week. And video was only available when needed, and mostly through non-telemedicine platforms. So again, things like FaceTime, etc. Private hospitals here were doing it, but at a very small scale. And laws and regulations, again, like the US did, just completely relaxed and allowed things like prescriptions over phone, etc. Now, what happened in Egypt? Again, Egypt didn't really switch into large-scale telemedicine. What happened was, again, the public sector started some kind of call centers to receive calls about coronavirus, etc. Some companies also started using it in the private sector, but they tried to do it through other platforms like WhatsApp and FaceTime. Again, all of these platforms are not HIPAA compliant, they're not secure enough, and you have to move between different things to get the care that you need. So people were just trying to kind of come up with different ways of doing it because no one had invested in building a good telemedicine platform before that. No prohibiting laws or regulations were in Egypt. And here I wanted to spend some time talking about data. So who's using telehealth in MENA after Corona, or in Egypt specifically, and how did the usage change? So here, again, there's no published studies about numbers in Egypt, but I'm gonna show you some of the data that we have from Ember. This is unpublished stuff. So you can see here that from January to June, you know, usage rate increased by more than 5.8 times. So that's more than 500%. Again, matches the numbers in the US. The number of calls and users increased. Now, who's using telemedicine in the region? So we can see it was mostly females, and most of them are in the age range of 21 to 40. Again, remember, almost 95% of people in MENA are less than 65. So this young group also matches kind of the younger population in the MENA region. And they are the most tech savvy. Now, this is an interesting analysis where we started looking at, okay, who is using us and what are they using us for? And you can see here that one of the biggest things that we've seen, I think this is really remarkable, is that almost half of our calls are psychiatry related. And we have some peds, OB-GYN, derma, cardiology, some GP stuff. But psychiatry represents a huge amount of the number of calls that we were getting. Again, also something very interesting that we noticed in the MENA region is that, unlike what Dr. Ramtekar mentioned earlier, so in the US, it's very, most of the visits are done through video. Again, and this is because video is reimbursed in the US while live texting is not. But here in Egypt, we found that almost 85% prefer to use texting over video. And the reason is, when we started asking, is we've got these comments from people, from these younger patients who actually, a lot of them live with their parents or live with their spouses, and they were like, well, I love texting in the app because I can sit there on the couch, chat with you, and no one would know that I'm chatting to a psychiatrist. They think I'm just texting with my friends. Versus if you decide to talk to a doctor through a video, you gotta go to your room and kind of, you're always worried about people hearing you. So that's something that is very interesting. And again, matches the whole taboo idea. And we've, throughout the last 6 months, we've gotten tons of downloads. We have more than 50,000 users, more than 1,000 doctors, and really positive feedback. Again, because we had planned this before Corona, not knowing what was coming, but it just happened, and I think we were right there just to support people as this happened. So now I'm going to shift gears a little bit, quickly talk about scenes in other countries. So again, Saudi Arabia, UAE, Kuwait, for example. There's been talks about it. There's some hospitals that have been using it, but again, nothing large scale, nothing like the US at all in terms of the total number of visits. Again, mostly private hospitals and clinics there. Laws and regulations, again, were relaxed. So everyone's like, we wish we had really invested in telemedicine in the last, 5 to 10 years, because then when Corona came, our lives would have been much easier. Now, but is it too late? And the question is, will the MENA region go back to the BC era or the before Corona era and abandon telemedicine? Or is Corona going to serve as a catalyst that's just going to, accelerate us into a new era of adopting telemedicine? And, because everyone really loves telemedicine now, doctors, patients. And again, we're not talking about it as a replacement for in-person visits. We're talking about it as a tool that helps you practice medicine. So there's no going back. Patients love it, doctors love it, provides clinical value, it's cost effective, and technology and globalization are progressing, right? So technologies are improving, 5G networks, So there's no way we're gonna go back. There's no way. So now moving forward, what are the challenges that we gotta overcome to achieve widespread adoption? So I'm gonna go through them quickly because most of them were covered by the speakers, but I'm gonna go through them quickly with a focus on the MENA region. So let's talk about technology. So again, as Dr. Suleiman has pointed out in his talk, you gotta look at all these different apps and different platforms that you have, because you kind of gotta choose what you think you like and suits you and also suits your patients. So are you looking for a desktop platform, an app platform, something that supports both? Are you looking for something that supports different specialties, or just something that is specifically for general practitioners? Again, a lot of the Western solutions, again, some of the, if you have Epic, which is an EHR and has telehealth, Epic is not available in the Middle East. Some countries like, companies like Teladoc or American One are not available. And even if they're available, they don't support the languages. So none supports Arabic language. So we gotta find or come up with our own platforms in the region. Now, payment platforms, again, how are people gonna pay? So again, fintech is still not very well developed in the MENA region. It's much better, of course, than it used to be, but needs to develop further. Dealing with technological failures. Again, some countries are better than the others. Some countries have 5G networks and some are still kind of getting there. So you'll get more technological failures there. So how do you deal with them? But again, this is stuff that's going to improve. Things here that we have to start doing as people do in the US. We got to start coming up with our own customized privacy policies, data user agreements. And these need to be, again, they need to take into account different countries and the rules, but they also need to be as general as possible so that it applies to different countries or different locations. And then things like integration with remote monitoring devices. This is also something that is not very well developed here. How do we use your Apple Watch data, etc., and integrate it with telemedicine? Legal challenges in the MENA region. There is almost lack of any developed telemedicine practice laws in most countries. There is nothing that is really, well developed at all. Who is licensed to do telemedicine? Can any doctor do telemedicine, or do you need a specific kind of training? What about prescriptions? Can you do prescriptions over telemedicine? Can you not? Again, different countries will have different laws, but we need to start developing these in the next, few years. And the question is, while we're developing these laws, since we're going to be working on it now, who can practice telemedicine? And is it really controllable? If a patient in Qatar uses their phone or FaceTime and speaks to a doctor in Egypt, can you actually tell them no, or this is prohibited, although the doctor in Egypt is not licensed by Qatar's kind of licensing institution? You can't, right? Because the patient is willing to do it. It's the patient's choice and they want to do so. And you're not going to chase every patient who wants to talk to a doctor. So we really need to think about this as we're developing this. We can't really restrict patients in the era of technology. It's very difficult. Now, what about malpractice laws? Again, almost non-existent. So what do we do with malpractice laws? We have to develop them. Again, what happens if a doctor in Qatar, if a patient in Qatar talks to a doctor in the US? Let's say there's a medical error. What can the patient do? Do they have to go to the doctor in the US, etc.? And again, these questions are very important, because the more you think about them, the more we wonder if eventually, since technology is global and ubiquitous, are we eventually going to reach a state where there's going to be global practice laws for telemedicine, or maybe even lack of laws, and it's just going to be kind of do whatever you want, just as long as like, let's say you can just sue a doctor in their country of practice or something like that. But this is interesting. It's going to be interesting to see how this develops eventually. Legal challenges, again, cybersecurity is a huge thing. Now this has been, the HIPAA compliance kind of rule was changed just to promote more use of telemedicine. But this is something that we really have to think about in the next few months. As we're going to start coming up with these laws, we have to make sure that these systems are secure. Now, other things that we need to worry about, setting expectations. So now patients have their Apple Watch, it's recording their heart rate all the time. You don't want to be in a situation where the patient thinks you're reviewing their Apple Watch data all the time when you're not, because you're never going to do that, right? As a doctor, you don't have time to review every patient's data all the time. So you need to set very specific and strict expectations with the patient. I'm going to review your data once a month. I'm going to review your blood pressure from your Bluetooth device once a month, for example, so that the patient doesn't have unrealistic expectations. Now, what about reimbursement? Again, we are very behind on reimbursement. So we need to do things like start defining the actual value of telemedicine encounters. How much are they saving us per clinic visit, for transportation, for all of this stuff? We have to start doing what insurance companies in the US have done in the last 10 to 20 years. We have to, again, incorporate transportation costs, inconvenient costs. And depending on the value, then we can actually come up with a good number in terms of valuing these calls. Insurance companies need to, push forward, and again, their patients are demanding it, doctors are demanding it, so they need to kind of move forward with what this whole, like, patients and doctors want. And then what is the best payment model? Again, this is also something that even in the US, people insurance companies and CMS, etc., are trying to figure out. What is the best payment model? How do we incentivize doctors to do more telemedicine visits? How do we incentivize patients to do more telemedicine visits? And so on. And I think eventually this will progress to a world where insurance companies might incentivize doctors or hospitals to use more telemedicine. So the more telemedicine visits you have per year, then you'll get kind of a higher reimbursement. And eventually, in total, that will save the insurance companies money. Other challenges in the MENA region is with, again, cash payment. It's a very cash heavy. A lot of countries in the in the MENA region are cash heavy. So we need to work on developing all these systems. So for example, Egypt has 100 million people, but only 3 million credit cards. So how can we kind of, allow patients to pay for these services online through other means, like mobile cash or so? Now, ethical challenges. What about recording the encounter? I'll be having a call with a patient. What if the patient is recording the encounter? What if they're taking pictures and posting it on Twitter? So this is an important thing to consider. Are they allowed to do so? So some states like New York apparently allow the patients to do so. So you as a doctor need to be really aware, or you as a clinician, so you need to really be aware of all these laws. Who owns the data? All these the blood pressure data that the patient sends you. Who owns it? Who keeps it? Can it be used in research? So all of this needs to be thought about. Is it going to create a new health disparity where people who have high digital health literacy are using it more than others, and people with low socioeconomic status are not? Well, of course, it will create that kind of disparity, but there are some systems in the US now where some hospitals are doing loaner programs where they're loaning, again, some of these devices or tools like, simple smartphones or smartwatches to patients in order to improve their care. Because the idea here is that, if you help them pay for it, maybe they'll use it more, and maybe that eventually will improve their care. And then physical exam, I put it here in under ethical challenges, because some people are like, is it really ethical to do a physical exam on telemedicine? And I think this has been discussed in multiple other fields, and I'll just show you this very quickly. This is an examination of your jugular venous pressure, which tells you whether your volume overloaded or not. And this is a very recent study that showed that it correlates very closely to bedside jugular venous pressure. So yes, it can be done, and yes, it is ethical as long as you know what you're doing. And again, studies are done to validate this. Very important. Patient and doctor adoption, again, we need to work on this. Adoption depends on specialty. So again, we're seeing in the MENA region that adopting telepsychiatry is much faster. It's growing very quickly. Establishing trust with the doctor first. A lot of people are making this comment. Well, I want to have telemedicine visits, but I don't want to have my first visit with a doctor. I don't want it to be telemedicine. I want to see them in person, and then our follow-up visits can be through telemedicine, which is important. And I think telemedicine actually works very well for follow-up visits. I can, in my cardiology practice, I can probably see anywhere between 50 to 70% of my patients through telemedicine for follow-up. Now, to increase doctor adoption, again, we have to figure out these reimbursement legal considerations. What am I liable for? Can you sue me, etc. These kinds of things. Remember, it augments. We have to tell them that it augments your practice and doesn't replace it. It augments your practice and doesn't replace it. Unrealistic patient expectations. Again, we need to, this is not telemedicine. Doctors are scared that it will turn into the situation where a patient can just text you whenever they want. But that's the point of creating these formal platforms or formal technologies, that it can create this barrier that prevents patients and doctors from, the patients from reaching out to the doctors whenever they want. There's going to be certain limitations and barriers. Again, fear of adopting new technologies, but according to the Gartner hype cycle, you always get through this. And then figuring out the payment models. And then finally, I think evidence. Evidence is very important. There haven't been any well-designed studies in the MENA region at all to assess the value of telemedicine. And we need to look at this. We need to look at actual outcomes. Now, what is the value of telemedicine and how do we measure outcomes? Are outcomes considered to be improvement in clinical outcomes? Is that a reasonable endpoint? Well, maybe not. Actually, if you actually show equal outcomes, maybe that's a positive thing. If me talking to you through telemedicine provides equal clinical endpoints compared to an in-person visit, then that in itself proves that telemedicine works, and we have to look at cost effectiveness, because again, if I can get the same exact care without having to go to the doctor, without having to spend money on transportation, then this is something that is of value. So we need to look at what endpoints are we going to measure, and it needs to be clinical and, in my opinion, cost. Study its impact in different populations. We need to look at, again, different socioeconomic statuses and so on. And then we need to come up with evidence on how to integrate in our practices. Cardiologists integrate it in a way that's very different from psychiatrists. It's very different from, PMR specialists, neurologists, etc. So each specialty needs to look at the best practices of incorporating telemedicine. And this, for example, a study from my specialty, cardiac EP, where out of 100 visits, we're seeing the same numbers that I showed you in the surveys. Most doctors are loving it, and they'll do it again. And most patients have also had an excellent experience using it. So, is there hope with all these challenges? Yes. So how do we move forward? I'm very quickly gonna go through this. So again, technology. We need to build comprehensive technologies that are simple enough. We need to build language, so it needs to be compatible with Arabic and any other languages in the region. So for example, in Qatar, one of the most spoken languages is Tamil. So it should incorporate Tamil, for example. We need to think about these things. It needs to be interoperable, right? So again, works with different electronic health records. So if we have a telemedicine visit on Ember, can the note then be incorporated into Cerner? Because as a doctor, I don't want to have two very different systems working independently. So they need to be interoperable, and then figure out payment methods. Leadership. This is, I think, a huge step that we still haven't reached. Most of the leadership in the Middle East are behind on realizing the value of telemedicine. And this really needs to be pushed forward. Leadership in different countries in the region need to really think about the value of telemedicine now and 10 years ahead, 20 years ahead, 50 years ahead. We need to study its value, not just realize it. We need to implement the vision. So how is this going to be implemented across the whole country? Where, etc. Where is it more beneficial? So for example, in Egypt, is it more beneficial? It will be more beneficial in rural, underserved areas. Pushing the agenda with all stakeholders, pushing insurance companies to consider, reimbursing for it. And you can do this by encouraging public insurance reimbursement first, etc. Laws, again, this is part of leadership. Laws needs to be developed. Again, they need to be very progressive. We need to look 50, 100 years ahead, and maybe even think about a global perspective rather than just a very local perspective. Okay, I know a lot of people love coming up with laws and restricting things, but you can't do that anymore. We're not in this age. So you need to be as open as possible, integrate with multiple countries, just make life easier for patients who want to get care wherever they want. I always say that there's no reason for a patient in Egypt, for example, to not be able to see a doctor in the US or in Europe through telemedicine. There is no reason that they can't. We just need to provide them with the tool. And then malpractice laws, respecting patient choice, as I've mentioned. Pricing, we need to assess the cost effectiveness, something that's still lacking in the Middle East. What is the right price? Again, it needs to be cheaper than in-person visit, but it can be very cheap because otherwise doctors won't start using it. Insurance reimbursements, coming up with incentives, as I've discussed. We need to build our literature and our evidence. We need to start doing a lot more studies, like all the previous speakers have discussed. Research funding. So, for example, there really hasn't been any significant research funding in the Middle East for telemedicine studies or remote monitoring studies. So we really need to catch up. Industry needs to catch up. So one of the things that we plan to do as we grow is also lead some studies. We're trying to do some in the US and also some with some institutions in Egypt. Defining what outcomes are we going to look at, very important. And education. And this is what I really love about this webinar, is that we really need to educate healthcare professionals across all levels of seniority. And even I'd say telemedicine is one of the things where you really need to educate the seniors before the juniors. Like, this is one of the situations where we really need to go and start educating people at the top before we even educate people at the bottom, because the people on top are the ones who really drive all of this and its implementation. And I love how this webinar was organized by students who were teaching all of us and senior people about telemedicine and its applications all over the world, and that they really need to very quickly start establishing it here in the region. And this needs to be implemented, as Dr. Major has pointed out, across medical school, postgraduate training. There's now postgraduate training curricula in residency too about using telemedicine. In CME, CPD, lifelong learning, patient education. We need to educate patients how to use it and invest in it. As Dr. Ahmed had said, there's some studies showing that if you really invest in teaching the patients and they pick it up, they run with it. So actually older people, you would think that it's really hard to get them to use it, but if they use it once or twice and get a hold of it, then that's it. They'll just fly with it. They're like, this is the best thing ever. I'm not gonna go to a doctor again. And with this, I'm gonna leave you with this quote, which I love. No one knows who said it, but they'll say at first they'll ask you why you're doing it, and later they'll ask you how you did it. And that's what we wanna do with telemedicine. And thank you very much. I'll take any questions.
Thank you, Dr. Shazly, so much. It was a very comprehensive talk, and it actually answered some of the questions that the attendees put up as you gave the presentation. But I do have a question here for you. So how difficult is it to integrate Ember or other telemedicine platforms for hospitals of any size? Does this disproportionately affect rural areas?
So again, that's part of our vision. Actually, is when we started doing this, we started building this with recent technologies. So the idea here was to build really simple technologies and APIs, which are these back-end integration capabilities that allow us to integrate easily with any system. So let's say, for example, you want to integrate with Epic or Cerner, which are big electronic health record companies. They actually the problem would be more on their side, because they are really, because they're huge. They'll be kind of really you want to integrate with us, that kind of thing. But most of them actually allow it now because of the whole push to do interoperability. So we can do that. But again, if hospitals are using smaller like electronic health record systems or so on, then again, as long as the software developers are ready to integrate, it's not hard at all. And that's the cool thing about building these technologies now, is that you build it with ways that just make integration very, very easy. Again, if rural areas, so what we did with Ember2 is that we tried to build it also as a mini electronic health record. So if you're in a rural area and you don't even have a mini electronic health record, this can serve as one. So you can even use it for inpatient care a little bit and so on. I mean, that's again coming up in the future, not right now, but it can be your only platform if you're still using paperwork. So yeah, so again, part of it is just building it in a way that makes it really, really easily integratable with everything else.
Right. And you mentioned pricing also. Someone asked, does the cost effectiveness trickle down to the patient and the doctor? So doctors have complained that telehealth, at least in the US, causes a reduction in their salary. Is this dependent on the healthcare facilities policy or something else?
Yes. So just let me make it simple, because a lot of people don't really understand how the US system works. So the US system works by, the more you work, you generate things called RVUs. And depending on that, if you're in private healthcare, you determines your salary, how much money you make. Telemedicine reimburses less than in-person visits, or at least used to before Corona. So like if I'm spending half an hour of my time, half an hour of telemedicine is in general cheaper than half an hour of in-person care. So if I have the option of choosing this or that, I prefer in-person. But then what happened after Corona is that some rules were developed that they would actually reimburse in a similar amount to in-person visits, so that they would encourage people to use telemedicine. So it won't be prohibitory. So that's changing. And I think that's going to change in the future, and my thoughts about this, this is all still in development. My thoughts about this is that eventually CMS or other big insurers will tell hospitals, and again, they'll prove that it's cost effective. So they're like, okay, let's say as an insurance company, I have a patient. They were seen in person and they were seen through telemedicine. Telemedicine is cheaper for the insurance company. So they're going to go to the hospitals and be like, listen, if you do 1 million telemedicine visits a year, I'm going to give you an incentive, which is basically they'll pay them extra for these visits, or they'll give them a bulk sum or something. So then hospitals will be like, oh my God, if I actually do more telemedicine, I'm going to make more money, but the telemedicine saves more money, right? So it's like this tripartite of like insurance, insurance and doctor and patient. Everyone is happy. Insurance or the payer has saved money, doctor has made the same money or more money, and patient has saved themselves the inconvenience and cost. So that's what insurance, I think, eventually will develop into. Now, cash payments, it's a balance, and depends on every country, every specialty. So you have to find this right balance, but that you're not going to charge the patient an equal amount of money compared to an in-person visit, right? Because again, they technically, they don't feel like they're there seeing the doctor. So you'll charge them a little bit less, but it doesn't have to be a lot less, because otherwise the doctor won't, the doctor will be like, this is not beneficial for me. I'm not going to do it. So you always got to find that balance. And a lot of patients want to do it for cheap and for free, but then you'll have to tell them that it's the doctor who determines their fee, or it's the doctor who the doctor also needs to find value in doing this.
Yeah. And how will you promote continuity of care, where your doctor has access to your previous records from other doctors, etc.? Is there a shared electronic record or not?
Yep, exactly. That was the point again of at least what we did here was building this so that all of these notes and things like that are kept in an electronic health record format. So if the patient shares tests with the doctor, labs, if another doctor has written a few notes or whatever, all of that is saved. So again, it's like a mini electronic health record. I don't like to say it's a full electronic health record, because, for example, we're not building it to be able to, at least at this time, to be able to review echoes and all these things which require lots of storage, but at least reports and things like that are going to be available. And that was our sense initially, is to get this to be used and actually for people to love it. because a country like Egypt, electronic health records are, almost non-existent. So again, they really find value in all of these things in it. And then when we work in Qatar, if we're going to work with people who have electronic health records, we really want to integrate with them. So that let's say a doctor writes a note in our platform, then it gets pushed to the other platform. So it's there, it's recorded, all the details about it.
Okay.
And that's interoperability is a huge thing. It's very important.
And for the last question, how is Ember aiding in patient empowerment? So since the MENA area is behind on malpractice laws, where does Ember and other telehealth companies come in place?
Yes. So again, we have been on the scene for around 6 months now. So we weren't expecting that kind of explosive growth. I guess Corona helped us. Some people were lucky that Corona came in. So we have a lot of people now. So we're in the process of figuring all these things out. Again, I think what we're doing for patients, we're providing them with, all these different ways of talking to doctors. All the doctors, we review their credentials, we make sure things are done. If, of course, there's any complaints or anything about doctors, then we help the patients with it, as long as it's a reasonable complaint and so on. So again, we're a software provider that connects the patient with the doctor. And again, what we really want to do is just empower patients to use us. During Corona time, we had a lot of free calls for patients so that they can call, and this is for any specialty, not just for Corona complaints. So we try to do that too. So yeah, we've been doing a lot of community work, and I think over the time as we grow, we're gonna continue to do a lot more because this is super important.
Right.
Again, just knowing that a patient in south of Egypt can speak to a doctor in Cairo or Alexandria that they would have never been able to reach without like an 18-hour train ride or something like that. This is huge, especially in countries like Egypt.
All right. Thank you, Dr. Shazly, so much for giving us some of your time today. And
thank you very much, Toga, for organizing this, and it was a lovely session. Thank you to all the speakers.